Good morning to one and all. Today's seminar topic is pathophysiology of residual ridge resorption and its management. It will be covered under the following contents. So, introduction, alveolar bone, it is defined as the part of maxilla and mandible that forms and supports the sockets of teeth. And residual alveolar ridge by GPT-9 is defined as a portion of alveolar ridge and its soft tissue covering which remains following the removal or loss of teeth. It consists of denture-bearing mucosa, submucosa, periosteum, and alveolar bone. Now, tooth extraction. Post-extraction, a cascade of inflammatory reactions is immediately activated, and extraction socket is temporarily sealed by a blood clot. So, temporary blood clot formation is followed by calcification of intercellular substance. Epithelial tissue begins its proliferation and migration within the first week. Histologic evidence of active bone formation in the bottom of the socket is seen as early as possible in 2 weeks after extraction, and socket is progressively filled with new formed bone at the end of 6 months. So, residual ridge resorption, it is the term used for diminishing quality and quantity of the residual alveolar ridge after the teeth are removed. So, RRR is chronic, progressive, irreversible, and cumulative disease. The residual bony architecture of maxilla and mandible undergoes a lifelong catabolic remodeling. Rate of the reduction is maximum in the first 3 to 6 months, but continues throughout the life at a slow rate.
This conference will now be recorded.
Because of the wide variation in the rate of RRR from person to person and within the same person, residual ridge resorption is considered as a pathology rather than a normal physiologic process. Bull's law of bone transformation states that every change in the form and function of bone or their function alone is followed by certain definite changes in their internal architecture and equally definite alteration in their external conformation in accordance with the mathematical laws, which simply means that bone remodels in response to the force applied. However, the exact reference to the Bull's law in relation to bone resorption is an inadequate explanation of this complex physiological process. Classifications. Atwood's classification is the most common classification which is used. Order 1 is the pre-extraction. Tooth is in the socket with labial, lingual, and cortical plates merged with lamina dura. Order 2, post-extraction. Clot formation, reorganization, and epithelialization is present, but the edges of the ridge are still sharp. Order 3, high well-rounded. Cortical plates are rounded off by external resorption, narrowing of the crest, and remodeling of internal trabeculae bone is seen. Order 4 is knife edge ridge. Sharp narrowing of the labiolingual diameter of the crest of the ridge is seen. Order 5 is low well-rounded. Progressive labiolingual narrowing is seen, resulting in the low well-rounded ridge. And order 6 is eventual progressive resorption leads to depressed ridge. Lecombe and Zark classification. Type 1, almost entirely composed of homogeneous compact bone. Type 2, a thick layer of compact bone surrounds a core of dense trabeculae bone. Type 3, a thin layer of cortical bone surrounds a core of dense trabeculae bone. Type 4, a thin layer of cortical bone surrounds a core of low density trabeculae bone. New classes were added as subclasses of type 2 and type 3. So type 2A is the same as it's written here. Type 2B, thick layer of compact bone surrounding a medium density trabeculae bone. And type 2C is thick layer of compact bone surrounding a low density trabeculae bone. Modification was added also to type 3, that is type 3B is a thin layer of compact bone surrounding a medium density of trabeculae bone. Next was the misclassification of bone density. He divided the bone into D1, D2, D3 and D4. D1 is the dense cortical bone with the tactile sensation of oak or maple wood with the Hounsfield units of more than 1250. D2 bone was white pine wood tactile sensation and with Hounsfield units of 850 to 1250. It is found in the anterior mandible and posterior mandible. D3 bone was thin porous cortical bones surrounding fine trabeculae bone. It is seen in the anterior maxilla and the tactile sensation was like balsa bone. D4 is the fine trabeculae bone with Hounsfield units of 150 to 350 and the tactile sensation was like a styrofoam sheet. And B5 bone is the Hounsfield unit is less than 150 Hounsfield units, and it is known as the immature non-mineralized bone. Seibert's classification: Class 1, buccolingual loss of tissue with normal ridge and apicocoronal dimension. Class 2, apicocoronal loss of tissue with normal ridge in buccolingual dimension. Class 3 was the combined defect with loss of height and width. Modification was done by Allen in 1985, where Class A was apicocoronal loss of tissue, Class B was buccolingual loss of tissue, and C was combination. He also gave measurements into mild, medium, and severe. Mild was less than 3 mm, medium was 3 to 6, and severe was more than 6. Note that Seibert's Class 1 is nothing but Allen's Class B. According to the residual bone height by American College of Prosthodontics, this was for mandible. Type 1, height of 21 mm or greater, measured at the least vertical height of mandible. Type 2 was height of 16 to 20 mm, measured as the least vertical height of mandible. Type 3 was 11 to 15 mm, and type 4 was 10 mm or less. Wickel and Swope, Class 1, up to 1/3 of the original vertical height lost. Class 2, from 1/3 to 2/3 of the vertical height lost. And Class 3, 2/3 or more of the mandibular height lost. How this is measured, we'll see in the upcoming slides. Pathology of RRR, gross pathology. The basic structural change in residual ridge resorption is a reduction in the size of the bony ridge under mucoperiosteum. In order to provide a simplified method for categorizing the most common residual ridge configurations, the 6 orders of Atwood have already previously been described. Here we can see the careful imposition of tracings of lateral cephalogram. Basic concept of bone structure and its functional elements must be cleared before bone resorption can be understood. Osteocytes. These are small flattened rounded cells embedded in the bony lacunae. They are the main cells of the developed bone and are derived from mature osteoblasts. The main function of osteocytes is to maintain the bone vitality. It also plays an important role in maintaining the exchange of calcium between bone and extracellular fluid. Calcified cementing substance, it's nothing but the osteoid matrix, which is composed of polymerized glycoproteins and mineral salts, namely calcium carbonate and phosphate, which are bound to these protein substances. Osteoblasts, they are concerned with bone formation and are situated on the outer surface of the bone in the continuous layer. The functions of osteoblasts, they are responsible for synthesis of bony matrix and role in calcification. Osteoclasts, they are giant multinucleated cells found in the lacunae of bone matrix. The main function is bone resorption during remodeling, and bone resorption always requires simultaneous elimination of organic and inorganic components of the intercellular substance. Microscopic pathology. Microscopic study shows osteoclastic activity on outer surface of the residual ridge. Scalloped margins of Hoship's lacunae contain the osteoclasts, leading to resorption. Smooth periosteal lamellar bone is present on the lingual, inferior, and labial surface of the mandible. On the crest, the medullary type of trabecular bone is present. Presence of reversal line and new bone inside the residual ridge is also seen. Pathophysiology of residual ridge resorption. It is normal function of bone to undergo constant remodeling throughout life through the process of bone resorption and bone formation. Bone formation is forming and calcifying the intercellular substance. Bone resorption, the sequence of events in bone resorption, the first phase involves formation of osteoclastic progenitors in the hemopoietic tissues, followed by their vascular dissemination into the blood as pre-osteoclasts. The second phase involves activation of osteoclasts at the surface of the mineralized bone. Third phase involves activated osteoclasts resorbing the bone. TRAP is nothing but tartarate resistant acid phosphatase, plays a very important role in resorptive mechanism. HCl released by the osteoclast dissolves the hepatite and the organic matrix dissolved by the proteolytic enzyme like cathepsin K. Rank L is a member-bound tumor necrotic factor expressed by osteoblasts or stromal cells. Now, receptor activator of nuclear factor kappa B ligand is KL, the full form. When rank binds to rank L on the osteoclastic precursor, there is activation of the osteoclastic pathway. Therefore, the presence of rank L is very important to start the osteoclastic pathway. It has been shown that remodeling takes place in 3 dimensions, such that certain portions of bone become narrower to the extent that all existing cortical bone in the area is removed by external osteoclastic activity and is replaced by new cortical layer that is formed by simultaneous endosteal bone formation. Even if a great amount of residual ridge is removed in total, there is often a cortical layer of bone over the crest of the ridge. This means that new bone has been laid down inside the residual ridge in advance to external osteoclastic removal of the bone. The structural product of the inward growth is called endosteal bone. It is of 2 types. A convoluted whorled appearance. This happens due to the compacting of the trabeculae bone by deposition of layers of new bone on the old trabeculae bone. Or circumferential lamellae. This happens when the bone is laid down in layers on the endosteal side of smooth cortical bone. So in the first picture, we can see the convoluted whorled appearance, which is commonly seen in the residual ridges. And there was a study conducted where both convoluted and lamellar endosteal bone was found in the same specimen with resorption spaces. Endo's principle of bone remodeling. Principle of V, progressive growth of long bone in the direction of the arrow is accomplished by the additions in the inner surface, and minus means removal of the bone or the resorption. A modified version of Endo's principle was the inverted V, which explains the mechanism of reduction of mandibular residual ridge. Same way, minus is resorption on the external surface and endosteal deposition is depicted by plus. Pathophysiology of edentulous. Maxillary teeth generally are directed downward and outward. Therefore, the resorption is generally upward and inward. The amount of mandibular teeth generally inclined upward and forward to occlusal plane, whereas the posterior teeth are either vertical or inclined lingually. Hence, the resorption in mandible is downward and outward, making the mandible progressively wider. Therefore, to conclude, the resorption in maxilla is centripetal, which makes the bone narrower, and in mandible, the resorption is centrifugal, which makes the mandible wider. Pathogenesis of residual ridge resorption. Residual ridge resorption proceeds over a long period of time from one stage to next. The rate of atrophy varies greatly between different individuals, as said by Brass, and even within one and the same person at different times. The pathogenesis is highly variable. However, atrophy is greatest during the first year after tooth loss. The reduction of residual ridge is a lifelong process, but the rate of the bone loss does decreases as the years pass by. Talgren, Atwood and Coy studied the rate of residual ridge resorption for 25 years, and they came to a conclusion that mean ratio of anterior maxillary residual ridge resorption to mandibular was 1:4. The maxillary ridge is often broader, flatter and more cancellous than the mandibular ridge. The trabeculae and maxilla are oriented parallel to the direction of compression deformation, permitting maximum resistance to deformation. Therefore, the resorption in mandible is always greater than maxilla. Also, the mucoperiosteum, due to its spongy nature, has a damping effect on the forces that are transmitted to the alveolar ridge. Cancellous bone is ideally designed to absorb and dissipate such forces. And Frost, according to the Frost theory, Frost also stated that bones which are subjected largely to compression load and do not lead to bending loads are composed of cancellous bone, which is found more in maxilla. According to Bhaskar and Davenport, bone resorption in edentulous area is 8 times more than in dentate area in the same subject. Every effort should be taken to retain the natural teeth to the longest time possible. The physiologic masticatory forces applied via the roots of the teeth to the cancellous bone no longer persist when the teeth are removed. According to the Wolff's and Mechanophras theory, disuse loss of mechanical stimulation is followed by reduction in the bone loss. This is nothing but disuse atrophy. Rate of resorption, according to Boucher, first year after extraction, the reduction in the residual ridge height in the mid-sagittal plane is 2 to 3 mm for maxilla and 4 to 5 mm for mandible. And annual rate of reduction in height is 0.1 to 0.2 mm for mandible, and for maxilla it is 4 times lesser. Etiology, RRR is multifactorial biomechanical disease that results from a combination of these factors. Now, certain questions should be asked while evaluating the etiology. Anatomy. How much and what kind of bone does the dentist have to work with? Metabolic factors. What is the physiological capability of this bone to respond to treatment? Functional factors, what functional forces will be placed on this bone? And prosthetic factors, what technical details should be incorporated to minimize resorption in the prosthesis? Anatomical factors, mandible resorbs 4 times more than maxilla according to Tangerin. Larger alveolar process, more will be the resorption according to Victorin, because more amount of mass is to be resorbed. Bone density has no relation with residual ridge resorption as determined by Wilson and Atwood. Labial alveoloplasty gives more residual ridge resorption as evaluated by Gazzab et al. And short and square face associated with elevatory masticatory forces. These were the findings by certain studies. Metabolic factors. The 4 main levels of bone activity are equilibrium, growth, atrophy, and resorption. In equilibrium, see the figure A, both bone resorption and formation are in balance. So normal height of alveolar bone is achieved. The normal equilibrium may be upset and pathological bone loss may occur if either bone resorption or bone formation is more or decreased or both. Growth, the second factor, resorption is constantly taking place in remodeling as bones grow. So increased osteoblastic activity more than the resorption makes up for the lost bone during remodeling. Atrophy resulting from decreased osteoblastic activity as in case of osteoporosis and in case of disuse atrophy. The examples of resorption, it is caused by increased osteoclastic activity. Example is hyperparathyroidism and pressure resorption. Metabolic factors, residual ridge resorption is directly proportional to the bone resorption factors and inversely proportional to the bone formation factors. So RRR is directly related to certain local and systemic factors. Local factors such as prostaglandins, heparin, endotoxin from dental plaque, and trauma from ill-fitting dentures leads to residual ridge resorption. Certain systemic factors like glucocorticoid therapy. Glucocorticoid therapy in normal doses will not cause resorption, but when there is excess corticosteroids, there is bone loss, parathormone and estrogen deficiency. According to Riefenstein, he states that in young person there is relative predominance of the anabolic hormones like estrogen and testosterone over the anti-anabolic hormones like cortisone and hydrocortisone, resulting in the continued growth of skeleton. So at some point in normal young adult, the anabolic and anti-anabolic hormones are in balance, with the result that bone formation and resorption are in equilibrium. Therefore, the bone mass remains constant. He also added, as people get older, the anabolic hormones are so reduced that the anti-anabolic hormones like corticosteroids are in relative excess, with the result that bone resorption may take place faster than the bone formation. Mechanical factors, the reaction of bone to pressure is paradoxic, which leads to opposition and resorption of bone. It is well known that osteoid tissue receives constant mechanical stimuli that maintains a balance between osteoclastic activity and osteoblastic activity. So what is disuse atrophy? Now, when bone is in the state of immobilization or a weightlessness environment, the reduced mechanical stress cannot sustain the normal remodeling process, which results in the decrease of the mass known as disuse atrophy. On the other hand, it has also been postulated that physiologically applied mechanical force can stimulate bone deposition. Several studies have shown that in patients wearing complete dentures, the reduction of residual ridge was more than in patients without dentures, according to Campbell and Carlson. As an explanatory concept, pressure atrophy is particularly plausible for ill-fitting dentures. Other philosophy, by contrast, is atrophy was described in patients without the prosthetic treatment because there is no internal stimuli. This was given by Ferguson, supporting the concept of disuse atrophy. Functional factors, amount of force, frequency, duration, direction, and area over which the force is distributed should be considered. Residual ridge resorption is disuse atrophy or abuse bone resorption. Forces within the physiological limits are beneficial in their massaging effect. On the other hand, increased or sustained pressure produces bone resorption. When are the functional factors of frequency, intensity, duration, and direction are pathologic, whether they are, what is the dividing line between the stimulation and trauma or between use and disuse? The dividing line is not same for all patients because residual ridge resorption is highly variable. What to one patient is stimulation conductive to bone formation could be a trauma to another patient. Therefore, functional factors must be interacted in conjugation with metabolic, anatomic, and prosthetic factors. Wolf et al. has cited that the projected maxillary denture bearing area to be 4.2 square inch and 2.3 square inch per mandible, which is in the approximate ratio of 1:8:1, 1.8:1. If the patient bites with a pressure of 50 lbs, this is calculated to be 12 lbs square under maxillary denture and 21 lbs per square under mandibular denture. The significant difference between the two force, so there is more force per mandible, may be a positive factor to cause a difference in the rates of resorption. Prosthetic factors. Bone is moldable. It can tolerate masticatory forces within the limit of physiological tolerance, but exceeding can cause damaging forces known as resorption. So prosthetic factors like long continued use of ill-fitting dentures, underextended dentures, faulty impression procedure, lack of freeway space, incorrect centric relation, faults in the selection and placement of posterior teeth could be a factor for residual ridge resorption. Epidemiology. Till date, it would appear that RRR is worldwide, occurs in males and females, young and old, sickness and in health, with or without dentures, and is unrelated to the primary reason for the extraction of teeth. Rate of residual ridge resorption is variable between people within the same person at different times, within the same person at different sites. Genetics and RRR. Recent studies have shown the role of genetics in residual ridge resorption. Now, FGFR102P2/WIT 3.0 is a cytoskeleton molecule initially identified in oral wound fibroblasts and has been shown to induce oral mucosa contraction after dental extraction. So this study examined the genetic association between the single nucleotide polymorphism of this cytoskeletal molecule and excessive atrophy of the edentulous mandible. So the methodology, first the expression of the cytoskeletal molecule was determined in the gingival tissues of 8 subjects before and after extraction. So it proved that all subjects showed increase in this molecule post-extraction. Then in the separate study, 20 long-term edentulous patients were recruited. Each subject was asked to rinse the mouth with 20 ml of alcohol-free mouthwash for 30 seconds and then expectorate into a test tube. So mouthwash solution was stored in 4 degrees Celsius for 12 hours and DNA samples were prepared from the archived frozen samples. With the help of Tachman-based polymerase chain reaction, they identified the alleles of the cytoskeletal molecule, and it was concluded that patients with minor allele of RS840869 or RS859024 were associated with excessive atrophy of edentulous mandible. Influence of drugs on residual ridge resorption. Bisphosphonates, which is used in the treatment of osteoporosis, reduces the recruitment of clastic cells. It produces an inhibitory effect to osteoclast formation and induces osteoclast apoptosis. But the side effect is deterioration of the bone microarchitecture. NSAIDs inhibit the bone formation, fracture healing when given continuously. Anticoagulants like warfarin, which is used in vitamin K deficiency, induces vitamin K deficiency, predisposes patients to low bone density. Aluminum containing antacids bind phosphate, making it unresorbable by the gut. So excess aluminum containing antacids can cause hypophosphatemia, a metabolic bone disease. Corticosteroid suppression, it suppresses the intestinal calcium absorption. Therefore, indirectly, it activates the parathyroid hormone, and PTH causes bone resorption. Anti-cancer drugs have cytotoxic effect on osteoclasts and osteoblasts. Anti-epileptic drugs like carbamazine and phenytoin decreases the bioavailability of vitamin D, causes impaired calcium absorption and alterations in the bone formation and degradation. Consequences of residual ridge resorption: loss of sulcus width and depth, displacement of muscle attachment that is closer to the crest of the residual ridge, loss of vertical dimension of occlusion, which results in reduction of lower facial height, and anterior rotation of mandible, which is nothing but habitual prognathism, resorption of the mandibular canal wall, and exposure of the mandibular nerve. These provide serious problems to the clinician on how to provide adequate support, stability, and retention of the denture. Measurement of residual ridge resorption, serial examination of diagnostic casts, lateral cephalometric radiographs are the best to measure residual ridge resorption. Panoramic radiographs, a method by Wickel and Swoop. Original bone height is measured by calculating 3 times the distance between the inferior border of mandible to the lower edge of mental foramen. Prevention of residual ridge resorption. The best way to manage the problem of residual ridge resorption is using every measure to prevent it. So preventing the loss of teeth, correcting hormonal and nutritional deficiencies if any, conditioning of patient's musculature by jaw exercise and coordination, broad area of coverage to decrease the force per unit known as snowshoe effect, remove the dentures for at least 8 to 12 hours for maximum tissue rest, regular finger massage of the denture bearing mucosa. We will be seeing each of the management under the upcoming slides. So treatment of the systemic factors involved. Role of the systemic disease must be considered. Systemic conditions like osteoporosis, hormonal imbalance, and dietary deficiency play an important role in residual ridge resorption. Prosthodontists should always consider the possibility of systemic cause for gross alveolar resorption. Osteoporosis, according to a study conducted by Yakub Sanga, the study named as Prevalence of Osteoporosis in Postmenopausal Women and the Risk Factors in Indian Prospects, it was a cohort study. Osteoporosis is characterized by low bone mass and microarchitectural deterioration of the bone, which leads to increased fracture. So there are two types. Type 1 postmenopausal. This type is more common for residual ridge resorption, and type 2 is senile or idiopathic. Treatment is estrogen replacement therapy, calcium supplement, good nutrition and exercise, and bisphosphonate therapy. Osteoporosis strongly affects the reduction of the residual ridge in edentulous patient. This can be seen in radiographs as rare fractions in the skeleton. So dietary guidelines for the patients at the risk of losing bone. Patients with bone disease need a high diet in proteins, vitamins, and mineral content. So this was recommended by National Research Council of National Academy of Sciences. The daily requirement of protein should be approximately 3 ounces. Calcium should be, daily requirement is 800 mg. Phosphorus need is 1.5 to 3 gram daily. Tissue treatment therapy, soft conditioning materials can be used to rejuvenate the tissue denture bearing area. Hypertrophy tissue previously treated by surgery can also be reconditioned using this material. Prosthodontic management. Now design of the denture, broad area of coverage to decrease the force per unit area, snowshoe effect, decrease the number of dental units and decrease buccolingual width of the teeth. This is done to decrease the force to penetrate the bolus of food. Avoidance of any inclined planes. This is to minimize the dislodgement of denture and shear forces. Centralization of occlusal contacts. This is done to increase stability and maximize the compressive forces. And provision of adequate tongue groove. Method to improve denture foundation, use of temporary soft liner, regular finger massage to the denture bearing area, rest for the denture supporting tissues, correction of old prosthesis to restore the vertical dimension, good nutrition especially for the geriatric patients, conditioning of the patient musculature by jaw exercises, and preparing the patient psychologically. Prosthodontic management. The main aim of impression procedure is to gain maximum area of coverage. Selection of proper trays and correct impression procedure is very essential for an accurate impression. Residual ridges with adequate bone support. Conventional impression technique can be followed. In compromised residual ridges, the tissues become unsupported and displaceable. Therefore, conventional impression techniques will result in a distorted impression. So here, modified impression techniques is followed. The modified impression techniques is the first we'll see functional impression technique, which was given by Winkler. Overextended alginate primary impression is taken. Occlusal rims is constructed. Now 3 applications of tissue conditioning material in the interval of 8 to 10 minutes, and final wash impression is taken by light body material. Next is the dynamic impression technique. Here, over the custom tray, an acrylic stopper is built on each side in the premolar region to support the thermoplastic material. While the thermoplastic material is soft, the tray is placed on the lower ridge and patient is asked to close the mouth. So now the impression of the upper ridge will form on the lower thermoplastic material. Sufficient amount of irreversible hydrochloride is mixed with 50% more water and placed directly into the mouth. Tray is pressed through the alginate impression by digital pressure until the stops are firmly seated on the residual ridge. Ask the patient to swallow 3 to 4 times at 10 seconds interval. So this technique results in proper extension of the lingual denture flange of the finished denture. Next is the admix technique. This was given by McCord and Tyson in 1997. So this was indicated for flat lower ridge with atrophic mucosa. Here, 3 parts of red, that is impression compound, and 7 parts of green, that is low modeling green stick compound, gives the final impression. Cocktail impression technique. Tray is fabricated with a cocktail is a combination of 3 different techniques. So impression tray with auto-polymerizing acrylic resin according to the dynamic impression technique. Impression material was according to the McCord and Tyson's 7:3 ratio. Closed mouth functional impression technique is used to make the final impression. Next is the all green technique. Here special tray with spacer wax is adapted on the resorbed anterior area. All green impression is done, and then all scraping of the border molding compound, and then final impression is taken with high body addition silver. Comparison of different final impression techniques for management of resorbed mandibular ridge, a case report. This is the atrophic mandibular ridge. So different techniques were used. First one is conventional, second is the admix technique, next is all green, then is the cocktail impression, functional and elastomeric. So all these impressions were compared and measured. The patient with retention appliance, it was measured by digital force measurement gauze. So according to the results, mandibular denture made with functional impression technique showed the highest mean values of complete denture retention, and denture made with green stick and zinc oxide final impression showed the lowest mean value of denture retention. Neutral zone technique. The neutral zone is an area where outward forces from the tongue are neutralized by the forces of lip and cheeks. So the teeth will not interfere with the normal muscle functions. So technique for the construction of mandibular denture and favorable for retention and stability of the denture. So here individual, this is the anatomy of the maxilla and mandibular ridge. Here individual trays were constructed and fabrication of occlusal rim was done. These rims are molded by muscle function, patient's neutral zone, and mandibular neutral zone rim included with plaster placed on buccal and lingual surfaces. So teeth are indexed like this, and teeth are set up exactly followed by the index. Next comes the denture base material. Cast metal denture base, main advantage is great accuracy of fit to the tissue by surface tension than acrylic denture base. Also prevents the acrylic warpage. Less time change under the base, less tissue change under the base of the denture, better thermal conductivity, and less deformation in function. Processed resilient line denture base, the greatest advantage of these are its cushioning effect upon the mucosa and its ability to spring back. So it is indicated in patients with no ridge, flat ridge, or severely undercut ridge, tora, etc. The lining is best when there is a minimum thickness of 2 mm. Case report, a novel technique to manage a severely resorbed ridge, a case report. So a 64-year-old patient reported to Goa Dental College complaining difficulty in chewing. On examination, severely mandibular ridge was observed. So in the first picture, lower wax rim is replaced with cell cure acrylic resin stopper. Neutral zone is recorded with the visco gel in the second picture. Then teeth arrangement is done according to the index like shown in the neutral zone technique. Self-curing acrylic resin is placed around the anterior teeth with 2 mm lead foil spacer placed in the posterior region. Heat cure acrylic resin placed with a resilient liner and finished polished denture. So here conventional maxillary denture was planned and mandibular complete denture incorporating a layer of resilient liner between the denture teeth and denture base, which acts as an equal stress distributor, was used. Selection of teeth and occlusion. Neutrocentric occlusion was given by Divan, who suggested 2 objectives of his occlusal scheme, which was neutralization of inclines and centralization of forces. This objective aids in stability without interfering with speech appearance and chewing capacity. So he had given 5 elements of his scheme. So the 5 elements were position, proportion, pitch, form, and number. Posterior teeth are positioned over the crest of the ridge so that the forces are perpendicular to the support area. This will avoid the shearing forces. Proportion: reduce the width of the teeth by 40%. This reduces the vertical and horizontal forces on the ridge. Pitch: occlusal plane is oriented parallel to the underlying ridge, so the force will be directly perpendicular to the ridge. Form: non-anatomic or flat tooth with no deflective inclines were used so that there is no interference with the mandibular movement. The number of posterior teeth should be reduced from 8 to 6. This reduces the magnitude of the occlusal force. Linear occlusion was given by William Goddard. According to this concept, stability of the prosthesis can be improved by using linear occlusal scheme and steeper occlusal plane. So there are three factors: 0-degree tooth opposed by bladed tooth. Now, arch requiring greater stability usually receives the bladed teeth. It's mostly mandible. Mandibular teeth are set up to a flat plane, and there is no anterior interference to protrusive or lateral movement. This non-interceptive occlusion provides a consistent vertical seating force in both centric and eccentric, hence transverse vector is eliminated. Groans and Stout also stated that anatomical and non-anatomical occlusal scheme transmit lateral forces to the denture and reduces the stability, and suggested that the linear occlusal scheme has a potential for creating the smallest lateral force component. Relative to each other, maxillary and mandibular residual ridge are known to be in a favorable position for normal arrangement of posterior teeth if the connecting line between the mid-ridge of maxillary and mandibular ridge is at an angle greater than 80 degrees. So if the angle is less than 80 degrees, it necessitates a cross-bite or reverse occlusion of the posterior teeth. Hollow denture: extra weight may cause accelerated resorption of the residual ridge even at rest. So in order to avoid this problem, hollow denture may be given. This may be applicable to situations where there is severe atrophy of the residual alveolar ridges. A 56-year-old patient reported the Department of Prosthodontics at VSPM Dental College, Nagpur. Past dental history revealed that the patient was denture wearer since 3 years and maxillary denture was loose. So figure 1 shows the resolved maxillary and mandibular edentulous ridge. Figure 2, trial maxillary denture sealed with the indexed definitive cast. Figure 3, template adapted on the duplicate trial denture. Figure 4, a base plate wax is adapted onto the stone cast and processed heat cure denture base is formed. In this figure, after deplasking, clear matrix was placed, like a biostar sheet was placed on a definitive cast using indexing. Now, an endodontic file with a rubber stopper was used to measure the space between matrix and the processed denture base. Here, vinyl polysiloxane putty adapted and shaped to the contours of matrix. It can be adapted using cyanoacrylate. In figure 7 and figure 8, figure 7, maxillary denture openings to remove the putty material, and figure 8 is the complete hollow denture. Overdenture: they are designed to distribute the masticatory load between edentulous ridge and abutments. So whenever feasible, residual roots should be retained. These roots help to transfer the occlusal forces to the alveolar bone through periodontal ligament. Proprioceptive feedback prevents the occlusal overload and thus preventing the bone resorption. Implant supported prosthesis can be used for providing implant supported or implant assisted prosthesis, which helps to avoid continuing residual ridge resorption. Advantages are: it ensures support, retention, and stability, improves the functional efficiency, and improves the level of patient satisfaction. Surgical management, vestibular extension procedures. The reduction in the alveolar bone size is frequently associated with encroachment of muscle attachments on the crest of the ridge. These serve to reduce the available denture bearing area and undermine the denture stability. Soft tissue vestibuloplasties, including localized mucosal flap to full arch vestibuloplasties, may be performed to increase the relative height and extent of the denture foundation. Ridge augmentation. These are the procedures designed to enlarge or increase the size, extent, quality of the deformed residual ridge. So the main aim of ridge augmentation is restoration of optimal ridge height and width, ridge form, vestibular depth, and optimum denture bearing area, protection of the neuromuscular bundle, establishment of proper inter-arch relationship, and improving patients' comfort for wearing the dentures. Surgical options for highly resorbed ridge in mandible alveolar distraction osteogenesis helps to facilitate a substantial amount of both hard and soft tissue regeneration. Alveolar distraction may be followed by implant placement and prosthetic rehabilitation. In maxilla, advanced bone resorption may result in pneumatization of maxillary sinus and subsequent decrease in the height and width of the maxillary alveolar bone. Therefore, sinus lift osteotomy is followed by grafting can be used. Conclusion: residual ridge resorption is chronic, progressive, irreversible, and visibly disease of multifactorial origin. Much is known about its pathology and pathophysiology, but a lot remains to know about its pathogenesis, epidemiology, and etiology. Resorbed ridge requires a multiple approach for diagnosis and treatment planning. The cause must be detected by aid of a physician and then eliminated or stabilized before dentures are constructed. The patient should be educated regarding the type of treatment that is ideal for them and the prognosis for their treatment outcomes. These are my references. Thank you.